So I'll start by saying that germline or inherited TP53 mutations are associated with Li-Fraumeni syndrome, which is a rare hereditary cancer syndrome resulting in high risk for many different cancer types. But with broad germline panel testing, as well as recognized less penetrant mutations in the TP53 gene, we've observed an expanding phenotype of LFS. And at the same time, studies have shown a high rate of somatic TP53 mutations identified on hereditary cancer panels. And these somatic acquired variants in the TP53 gene confined to a clonal subpopulation in the blood can occur due to the normal aging process. And this aberrant clonal expansion has also been associated with chemotherapy and radiation treatment as well. So we've come to a crossroads where we are identifying TP53 mutations in individuals who do not have the typical phenotype of LFS. And because the peripheral blood is the standard sample used for germline testing, we have to speculate whether these mutations are associated with LFS and mosaic LFS, which is a subset of those with LFS, or whether they are somatic and acquired later in life, which makes a clinically significant difference in management of these individuals and their families. So our objective was to determine germline versus somatic status of TP53 mutations detected in patients who underwent panel testing on blood or saliva. When we identified these positive patients, those who did not meet clinical criteria for LFS were further evaluated by ancillary testing of other tissue types. And our main findings showed that out of the overall patients with a TP53 mutation, 54% were found to have germline variants. And we know that this will only become a growing challenge for clinicians as germline testing with hereditary cancer panels becomes more common. And we encourage clinicians to consider the possibility of non-germline variants and utilize multiple strategies of ancillary testing when the phenotype is not consistent with LFS.